డేవిడ్ మేడం చెప్పారు అలా కానిచ్చే.
అలాగే అన్న, అలాగే. హార్పర్ మేడం వచ్చారు కదా. గుడ్ మార్నింగ్ మేడం.
మార్నింగ్ డేవిడ్.
ఎస్ మేడం.
ఎంతమంది జాయిన్ అయ్యారు? ఇంకొక 2 minutes ఆగుదామా?
12 members వచ్చారు. మనం స్టార్ట్ చేస్తే ఇంట్రొడక్షన్ మెల్లిగా జాయిన్ అయిపోతారు, వచ్చేస్తారులే. ఓకే మేడం, వి విల్ స్టార్ట్.
గుడ్ మార్నింగ్ రాణి మేడం. థ్యాంక్ యూ.
Good morning all of you. Today Dr. Tripti Yerramilli is going to talk on good morning sir.
Good morning. Topic మారిపోయిందా sir?
Yeah, topic మారిపోయింది. On emergency basis they have changed the topic.
Okay sir.
Thank
Good
you
morning
Rani
sir. Mohan sir.
Providing the
Good morning sir.
speaker on the crisis. I request Dr. Rani madam to introduce the speaker.
Hello, good morning. Today, Dr. Tripti Yerramilli, she is our IDCCM student, and she did MD anesthesia and was working as assistant professor in KGH before coming to us. She's going to talk on community-acquired pneumonia today. So, Dr. Tripti, over to you. You can start your talk. Thank you.
Good morning, one and all. It gives me great pleasure to actually be in front of all of you and present this topic. The topic is community-acquired pneumonia. So, coming to community-acquired pneumonia, the most important thing which one should be acquainted in a case of community-acquired pneumonia is the timing. Is the timing of presentation. It is important to know that patients who have their first bacterial culture positive within 48 hours of hospital administration, the 48 hours time frame is very important, and they have to present within 48 hours of hospital admission. That is important, and they should be lacking the risk factors for healthcare associated pneumonia. So healthcare associated pneumonia is again a relatively new term, and healthcare associated pneumonia is very commonly seen in people who are already suffering from severe health issues, like them being immunocompromised or any such related issues. So it is within 48 hours of hospital admission. An important thing to note is CAP is one of the most debilitating, and it has a very high incidence of requiring healthcare. And the annual incidence of CAP in our society is almost 3 to 40 cases per 1,000 population. If you see hospital admission rates for CAP, it is very important to know that CAP admissions tremendously rise once one hits 65 years of age. So if you see the hospital admission rate for CAP, it is like 1,830 per 1 lakh population once a person reaches 65 years of age, and it is almost only 200 per 1 lakh cases when the hospital admission rates are less than, like when the age is less than 65 years. And coming to the overall mortality, it is still one of the leading causes of mortality in hospitalized patients, with 6% being at 30 days. Another important thing to add here is patients who have got COPD, their mortality rates once they're affected with CAP are very much more higher at about 9% at 30 days. So this is about the CAP in general. sir, I'm not able to go forward. Coming to the clinical manifestations of CAP, the community-acquired pneumonia can present in both forms, that is systemic as well as respiratory manifestations. One of the most common symptoms which a patient presents with is fever. Mainly the fever is high grade. It is associated with the sputum is productive. The color of the sputum again varies according to the pathogen. It is when there is coughing, it can be associated with the pleuritic chest pain. The patient can present with varying degrees of dyspnea. There is tachypnea when the involvement is multilobar. There can be a pleural lub, and on inspiration, on auscultation, there can be inspiratory crackles. So this is one of the common presentations of CAP. The classical signs of CAP are present in less than 25% of the patients only. And when the disease progresses in severity, then there is multi-organ involvement leading to MODS and sepsis. There can be septic shock. An important thing to note is that in the elderly patients, almost more than 50% have non-respiratory symptoms also, and as many as 1/3 can have no systemic signs of infection at all. Coming to the etiology, streptococcal pneumonia still remains one of the most common causative organisms of CAP. Another important thing to note in case of streptococcal pneumonia is these days the incidence of streptococcal pneumonia has been on the decline because there has been advent of pneumococcal vaccines, as well as there is an increased awareness in the population regarding the hazards of smoking. So cigarette cessation, smoking cessation, as well as the advent of the vaccinations have reduced the incidence of streptococcal pneumonia. Other common or pathogens which are implicated in CAP are Haemophilus influenzae, Staphylococcus aureus, Moraxella catarrhalis, Pseudomonas aeruginosa, gram-negative bacilli, and MRSA. Again, we have atypical bacteria associated with CAP, namely Legionella species, Mycoplasma pneumonia, and the Chlamydia pneumonia. An important etiology remains the viral, which is the influenza, respiratory syncytial virus, parainfluenza, adeno, corona, and rhinoviruses. Patients who give a history of working in dairy farms or those who are amidst farm animals, they commonly, we should also suspect zoonotic component in them, like Coxiella burnetii, Chlamydophilia psittaci. Tularemia. Tularemia is again seen in those who are in close association with rabbits. And then the etiology completely differs a bit when it comes to immunocompromised hosts. Recently, we have seen the SARS-CoV-2 pandemic, which also caused pneumonias in many individuals. Now, coming to an important component in the etiology with regard to the immunocompromised host. Many a time, people who are immunocompromised, and then the pathogenicity can slightly vary. Coming to a pneumonia, which is caused in a patient with neutropenia. Very commonly, we see all the organisms which I have listed above. Along with that, we can see fungal components. We do see Aspergillus species. We can see Candida in them. Again, an important aspect in our treatment is the human immunodeficiency virus. In HIV positive individuals, very commonly we see when the CD4 cell counts fall down, we see pneumocystis carinii infection, Mycobacterium tuberculosis, Histoplasma capsulatum, fungi, and very commonly cytomegalovirus is also seen. Coming to bone marrow transplant patients, commonly we see all the organisms which are listed above. A patient with cystic fibrosis may present with Haemophilus influenza, Staph aureus, Pseudomonas aeruginosa. And another peculiar characteristic which is unique to cystic fibrosis is Burkholderia cepacia. This species, this organism is also commonly seen in cystic fibrosis. Any patient who has got a complication like lung abscess, the species which are identified are bacterioid species, Streptococcus, Fusobacterium, Nocardia, and amoebic. And empyema, you have, because it is sputum producing, you have Staph aureus, Streptococcus pneumoniae, commonly group A Streptococci, Haemophilus influenzae. Anaerobic species can be seen, along with Enterobacteriaceae and many a times Mycobacterium tuberculosis also. So organisms that are virtually always pathogens when recovered from respiratory secretions are Legionella, Chlamydia, tuberculosis, influenza, and all the organisms along with, sometimes we can also see strongyloides, toxoplasma, histoplasma capsulatum, Coccus neoformis. Cryptococcus is again seen in the immunocompromised. In respiratory secretions, these are the organisms that are almost always virtually pathogenic. In special circumstances, I would like to address is whenever we have patients who have been IV drug abusers or IV drug addicts, in them the organisms commonly isolated are Staph aureus, Mycobacterium tuberculosis, methicillin-resistant Staph aureus, Streptococcus pneumoniae, and anaerobe. Patients who come with end-stage renal disease, you have MRSA. And then the special thing, air conditioning. Air conditioning can also prolonged non-cleaning of the air conditions. We do see Legionella pneumophilia commonly in these patients. So now coming to the assessment of severity of CAP, what is important is when it comes to the treatment, it is very important that we actually risk stratify the patient, because risk stratification is very important in administration of the treatment, and that is a vital thing in the treatment of any patient. It can actually lead to lessen the complications. So there are few risk stratification criteria, the most commonly being the curve. We will see one by one each. The commonly being curve 65 score. Then we have a pneumonia severity index, and then the American Thoracic Society and Infectious Diseases. So these are the common risk stratification scores, while assessing a patient with CAP. So important in this is the American Thoracic Society. I'm going to go to the next slide, which shows that any patient who meets one major criteria or at least three minor criteria of ATS has to be admitted to the ICU. So the severe major criteria includes any patient who comes with a pneumonia along with septic shock. And the important thing to note is a septic shock which needs the use of vasopressors. So that comes under major criteria. And along with that, respiratory failure requiring mechanical ventilation. So one of these two criteria, that is septic shock with vasopressors and respiratory failure requiring mechanical ventilation. So one major criteria or three or minor criteria. So minor criteria is like when the patient is tachypneic with a respiratory rate of more than 30 breaths per minute, or the PaO2 or FiO2 ratio less than 250. When you see that there is a multi-lobar infiltration, the patient is having altered sensorium, like confusion, disorientation, when the BUN criteria is more than 20 milligrams per deciliter. Any patient having leukopenia, thrombocytopenia, is hypothermic, and also who is requiring aggressive fluid resuscitation. Or one major criteria classifies for hospital admission. Then we have the curve 65 score. Curve C stands for confusion, U for blood uremia, R for respiratory rate, and B for the blood pressure. So whenever the BUN is greater than 20 milligrams per deciliter, the respiratory rate being high, the patient is tachypneic, more than 30 breaths per minute, a diastolic and a systolic blood pressure of less than 90, and a diastolic less than 60. Basically, when the patient is in hypotension, and also age, like I have mentioned before, the admission rates for CAP tremendously increase once the age hits 65 years of age. So whenever there is a score of 1 or 0, then probably we can, this patient may be considered for outpatient management. But if the score is more than or equal to 2, then it classifies under severe CAP, and this patient will require, and it is recommended that we hospitalize these patients. So that is the curve 65 score. Then there is the pneumonia severity index. The pneumonia severity index again takes into consideration multiple parameters of a patient. And based on these parameters, there is a Roman classification of 1 to 5. When it comes to pneumonia severity of index of 1 or 2, then the patient can be treated as an outpatient category. And then the pneumonia severity index is 4 or 5, then he requires admission, hospital admission. Coming to a patient, the risk factors present in patients at risk for infection with drug-resistant organisms. Nowadays, the burning issue in medical field is the emergence of drug-resistant strains. So when it comes to the factors which pose the risk factors are whenever a patient has been hospitalized for more than 2 days in the previous 9 months, or there has been an antibiotic use in the last 3 months, residents of nursing homes or long-term treatment facilities, any family member residing with the patient who is diagnosed with MDR pathogen, whenever there is a home wound care or domiciliary infusion therapy, patients with different comorbidities like hepatic, renal patients who undergo maintenance hemodialysis or who are undergoing chronic dialysis, COPD patients, patients with diabetes, severe diabetes, cardiac disease, patients whose spleen has been removed, which is asthenia, and any patients who are on immunosuppressive drugs or corticosteroids. All these various category of patients, we have to keep in mind that they can be actually associated with drug-resistant organisms. The infection can be drug-resistant. Now, coming to investigations and testing. Testing is usually recommended for all the patients who are hospitalized. We need to do gram staining, sputum cultures, ET aspirates in intubated patients, blood cultures. Again, when it comes to urinary antigens, it is very important that Legionella and pneumococcus can be identified by urinary antigens. Multiple PCR arrays can be are useful in Chlamydia, pneumonia, Mycoplasma, and RSV viruses. In advanced the infection, whenever the above have not been very useful, then we go for bronchoscopic lavage, and then the lavage can be sent for culture, gram staining, and PCR arrays. And influenza, in case of influenza, rapid test or a PCR can be used. All these are recommended for those who are hospitalized. And routine investigations, like for every patient, we can do routine investigations like complete blood picture, CRP, LFT, RFT to rule out any comorbidities or involvement, coagulation profile, blood glucose levels, ABG, when the patient is severely ill or when the first contact into the emergency department. Any CT chest X-ray is usually done. Echo can be done whenever we suspect any associated cardiac abnormalities. PCT testing is not routinely recommended, but it can be done to see whether a patient is having any superimposed bacterial infection whenever viral pneumonias are suspected. And like I've already, there is a category of patients who are the non-responders. These non-responders are those patients where you provide antibiotics, you give treatment, but they are not responding to the treatment. Usually the time frame is 72 hours. Despite giving treatment to patients, and they are not responding within the first 72 hours, they usually come under the category of non-responders. In them, we can actually do the following investigations, like biopsy can be done with analysis of the bowel fluid. Usually, these patients might go in for mechanical ventilation, and then so the ET culture is to be sent. Serology for HIV because immunocompromisation can be suspected, H1N1, and then other factors, other differential diagnosis should also be suspected in these patients. So an ANA or ANCA can be sent. BNP and pro-BNP levels. Whenever a pulmonary embolism is being suspected, then a D-dimer or venous Doppler or flow length can be sent. Ultrasound chest or CT chest can be done in order to rule out any complications of pneumonia. So this is the workup for non-responders. So the differential diagnosis of CAP is like pulmonary embolism, lung malignancy, hypersensitive pneumonitis, vaginal granulomatosis, ARDS, pulmonary edema, eosinophilic pneumonia, foreign body sometimes, and interstitial lung disease. Mostly a differential diagnosis is considered because the patient is not responding to the standard traditional treatment of CAP, and it comes under the non-infectious forms of non-responders, DDs. Coming to the treatment of CAP, it is very important. Like I said, the risk stratification is very important. And when the contact of the patient to the emergency department, initial resuscitation, starting of the empirical antibiotic treatment, that is the timing of the antibiotic treatment is important. Along with that, the care that should be with the patient. Then, like I've already said about the non-responders, what is the duration of antibiotic treatment and certain key preventive measures. So these are all the various treatment aspects of CAP. We'll see one by one. Approach to a patient of CAP. So whenever there is severe CAP, what we need to do is we need to classify if there is a risk of pseudomonas, which is very commonly seen in recent hospitalizations, or COPD bronchiectasis. In them, you have to see whether the patient is allergic to beta-lactam antibiotics. If the patient is allergic, go for aztreonam and levofloxacin, or go for a piperacillin, tazobactam, meropenem, imipenem. And if the patient is not at risk of beta-lactam, then go for fluoroquinolones or clindamycin. And if there is...
Okay, carry on.
Okay. So we go for a third generation cephalosporin or ampicillin sulbactam combination. An important thing which I have to address is the type of antibiotic. First comes to the ER. There should be no delay in administrating the antibiotic. Antibiotics should actually be given in the first hour of contact at the ER itself. Delay for culture or sensitivity, taking the blood samples for culture and sensitivity should not delay the administration of antibiotics. Whenever a culture sample has to be taken, ideally it should be taken before the administration of any antibiotic. But for that reason, one should not delay the administration of antibiotics. So antibiotic recommendations for ICU patients with bacterial acquired pneumonia, whenever you don't find a risk factor for pseudomonas, for community acquired MRSA, the recommended antibiotics are beta-lactam plus erythromycin, or beta-lactam plus respiratory fluoroquinolone, or a respiratory fluoroquinolone plus aztreonam. Whenever there is a risk factor for pseudomonas present, like I've already mentioned previously, anti-pseudomonal beta-lactam plus ciprofloxacin or levofloxacin, and anti-pseudomonal plus aminoglycoside or azithromycin, anti-pseudomonal beta-lactam plus aminoglycoside or along with the respiratory fluoroquinolone or aztreonam plus aminoglycosides plus a respiratory fluoroquinolone. All three multi-drugs can be given. Whenever the risk factor for community-acquired MRSA infection is present, then we need to add vancomycin or linezolid. So points of care, like I've already said, the first dose of antibiotic should be given in the first point of contact, preferably in the emergency department, and it should not be delayed for taking out samples for culture and sensitivity. Recommended duration is 5 to 7 days, though there have been many trials which recommend 7 to 10 days whenever the severity is more. But usually studies have shown that 5 to 7 days course is optimal. When the patient is not having a severe illness, then probably a dose can be prolonged to 7 to 10 days. Cat from Staph aureus or a gram-negative bacillus is usually treated for a duration of 2 to 4 weeks. Whenever we suspect Staph aureus cap with bacteremia, but without endocarditis, the treatment should be given for 4 weeks. At any given point of time, we have to see the culture reports and susceptible antibiotics should be given. So these are the points of care. Now coming to various scenarios, whenever a patient, like we have seen the various scoring systems, whenever a patient can be treated as an outpatient, and this patient has got no comorbidities, that is, the pneumonia is not severe in nature. There are no comorbidities, obviously, and the curve 65 score is less than 2, and the patient is able to take oral medications. In this patient, a macrolide or a doxycycline is antibiotic is recommended. So outpatient treatment in patients with comorbidities. In these patients, we have to add respiratory fluoroquinolone, that is now oxyfloxacin or levofloxacin, or a beta-lactam plus a macrolide is preferred in these patients. So these patients are those with comorbidities like probably diabetes or these kind of patients where they are fine, they are not having severe pneumonia, and they can be treated as outpatients. So in these patients, again, fluoroquinolones are added. Patients hospitalized in non-ICU settings. So in them also respiratory fluoroquinolone or beta-lactam plus a macrolide can be given. Now coming to the patients in ICU. In a patient who is present in ICU, a combination therapy is preferred. A combination therapy of, like I've already mentioned in the previous slides before, beta-lactam plus macrolide. In community-acquired MRSA and anti-MRSA, vancomycin or linezolid. Whenever an MDR Pseudomonas aeruginosa is suspected, colistin can be given. Patients with complicated influenza, oseltamivir or zanamivir is prescribed. Patients with superadded bacterial infection or antibiotic coverage for Staph aureus, ceftriaxone or vancomycin linezolid. An important thing to note is daptomycin is not recommended because it does not achieve therapeutic concentrations in the lungs. Again, there is a certain set of patients which have the risk of aspiration. These patients are those who are associated CVA, seizures, dysphagia, where they're not able to swallow properly, vomiting, head and neck cancers. In them, we have to add metronidazole or clindamycin. Coming to all patients, whenever the patient first comes to the ICU, we have to ensure that the airway patency is ensured. If the saturation is below 90% or an ABG shows a PaO2 at 2 liters of mercury, oxygen therapy or a high-flow-nasal cannula can be started in these patients. And if the acidosis is very severe or if there is hypercapnia, immediately transfer the patient to ICU. Every patient has to be assessed for volume status and administered IV fluids with or without vasopressor. Every patient might require a supportive therapy. Many times CAP is associated with multi-organ dysfunction or septic shock. Then we have to treat the patient according to surviving subsets guide. And the patient will be having COPD, asthma, and nebulization. Patients might require NIV, though the use of NIV has to be used with a lot of caution. The use of steroids is controversial. It is not recommended. And the only place where steroids are recommended are in septic shock, which are not responding to vasopressor. Severe CAP again might require invasive mechanical ventilation. Like I've said, who are the non-responders? Non-responders are those patients where you give antibiotics, but the severity of pneumonia is not reducing. Their clinical suffering is not reduced. The fever is still persistent. Despite 72 hours, there is no recovery, and these patients might progress to need for mechanical ventilation of septic shock. We have to review the culture in these patients or probably upgrade to a higher antibiotic. So whenever a non-responder is there, then we should also keep in mind the non-infectious causes. All the differential diagnoses which I have said before, they all should be considered in cases of non-responders. Also, we should see for or watch out for any kind of complications of CAP. So complications of CAP, very commonly in pneumococcal pneumonia, we can see a metastatic disease, patients presenting with arthritis, meningitis, endocarditis, and peritonitis. Sometimes there can be a parapneumonic effusion, which might just not, antibiotics might not help. So in addition to giving antibiotics, they might require a drainage with chest tube. The up-to-date guidelines suggest that the key prevention measure is the most important thing is cessation of smoking and also the use of pneumococcal or influenza vaccination. So these are the two very important key preventive measures, which is awareness about smoking cessation and pneumococcal influenza vaccination. I just felt, so that is the end of the CAP. I felt I could discuss few case scenarios with your permission, sir.
Please go ahead.
Yeah. So a 34-year case scenario 1, a 34-year-old male. This male he has no comorbidities and he was admitted to the ICU with history of fever 1 or 2 degrees. There was cough, productive sputum with yellowish white, which was yellowish white in nature. This patient has had a history of abdominal surgery. A scar could be seen on the left hypochondriac region. When we saw the vitals were like heart rate 160 per minute, that is high heart rate. BP is low, that is 90 by 40 millimeters of mercury. Saturation is also low, showing 86%. Patient was highly tachypneic with a respiratory rate of 40 per minute. The right lower zone consolidation, and investigations revealed low HB of 9.3, high TLC of 26,000, and a PCT was also done in this patient, which was more than 200. RFT and LFT were within normal limits. Your empirical antibiotic regimen should cover which of the following organisms? You can choose multiple. So the answers are chat box. So here the patient is a 34-year-old male and he has no comorbidities. But the clue in the history is a history of abdominal surgery and scar being in the left hypochondriac region. So probably this patient has undergone splenectomy. And whenever a patient has undergone splenectomy, they are very much susceptible to Streptococcus pneumoniae and Haemophilus influenzae. So this patient is probably suffering from Streptococcus pneumoniae and Haemophilus influenzae. So that is what has to be covered. The empirical antibiotic regimen should cover Streptococcus pneumoniae and Haemophilus influenzae. So that is case scenario 1.
Yeah, doctor. Yeah, 1 second, doctor. So when did this surgery? He underwent surgery.
So this is just a hypothetical situation, sir.
No, it's okay. See, why I asked is, if he came with the scar, it's okay. If he has come with recently, as you have already mentioned that the recent admissions and more than 48 hours, and if he stayed here in the hospital for 10 days and went to home and came back after 1 or 2 days, then that scenario is completely different.
Yes. Agreed.
Even though there is no scar or no splenectomy, the organism could be Streptococcus or MH influenza. The most common cause of CAP is that only. Yeah.
Yes.
Go ahead.
Okay. Case scenario 2 is Devi, a 28-year-old female. She is come with diarrhea, confusion, high-grade fever with bilateral pneumonia. The diagnosis probably is A. Legionella, B. Neisseria meningitis, C. Streptococcus pneumoniae, D. Haemophilus influenzae. So in this case, probably the diagnosis is Legionella, because Legionella commonly presents with confusion and diarrhea along with high-grade fever and bilateral pneumonia. So probably this female is having bilateral pneumonia with Legionella. Just for reference, Friedlander's pneumonia refers to pneumonia caused by. So Friedlander was the person who discovered Klebsiella pneumonia, and Friedlander's pneumonia is also known as Klebsiella. Klebsiella pneumonia is again commonly known as Friedlander's pneumonia. Case 3. This again comes likely persisting even after treatment of pneumonia. What is the likely diagnosis? So this again comes under the non-responder category. So the answer is probably A. Empyema, B. Fungal lesion, C. Carcinoma bronchus, D. Any of the above. So whenever a non-responder is there, we have to suspect either a complication of pneumonia, or we have to suspect the differential diagnosis of CAP. So the answer is any of the above. The same patient might be having or might have undergone complication for empyema. There can be an associated fungal lesion. There can be carcinoma bronchus. So a fever which is persisting even after treatment of pneumonia, any of the above is the most common cause of empyema. Empyema most commonly caused by bacterial pneumonia. So the most common cause of empyema is again bacterial pneumonia. Case 4. A truck driver presented with a history of fever since 4 weeks and dry cough. He also gives a history of weight loss around 10 kg. X-ray shows bilateral reticulonodular infiltrate. The most likely diagnosis is A. Tuberculosis, B. Pneumocystis carinii pneumonia, C. Pneumococcal pneumonia, D. Interstitial lung disease.
Usually it could be Pneumocystis carinii pneumonia.
Yes, sir. The answer is Pneumocystis carinii because though the history of fever since 4 days is there, it looks like sometimes a case of tuberculosis. But Pneumocystis carinii presents with dry cough, whereas many a times tuberculosis has associated hemoptysis mucoid component. The patient also typically gives a history of weight loss, which is again common in both tuberculosis and Pneumocystis carinii. An interesting thing to note here is the X-ray showing bilateral reticulonodular infiltrate. This X-ray showing bilateral reticulonodular infiltrates is not very common feature of tuberculosis, but it is a very common feature of pneumocystis carinii pneumonia. So the most likely diagnosis in this case is pneumocystis carinii pneumonia. Case 5. Ramu, 35-year-old male with no comorbidities and diagnosed with CAP. The preferred OP antibiotic treatment for him would be. So we have already seen scenarios where a patient, an outpatient patient who is being treated for outpatient and not any comorbid, when there is non-severe pneumonia, the curve score is less than 2, and the patient is able to take oral medications. For them, macrolide or doxycycline is recommended. So when we come to the case scenario 5, this patient Ramu, he does not have any comorbidities, and he's diagnosed with CAP, non-severe. So the preferred OP treatment for him would be a macrolide, which is clarithromycin. Thank you.
Thank you, Tripti. Very nice presentation.
Thank you, sir.
We go to the second or third case scenario.
Okay, sir.
Legionella pneumonia is the
Yes,
cause for this CAP.
yes,
And also
sir.
in Legionella, you will see the hyponatremia. Most commonly, you will see hyponatremia. The confusion, cause of confusion could be due to hyponatremia.
Yes, sir.
Yeah, whenever patient is having hyponatremia, old man with confusion, hemodynamically stable, so you should treat it as a Legionella along with coverage of other BLDLI to cover Streptococcus pneumonia rich influenza.
Yes, sir.
Another thing, the first case you said the patient came in shock. Okay,
Yes, sir.
Yeah.
Yes, sir.
90/40. It is a hypotension, tachycardia, tachypnea, PCT is very high. Young man. Okay.
Yes.
So, what antibiotic you will start for this patient?
Streptococcus pneumonia and Haemophilus influenzae.
What antibiotics you will start?
So we have to go for
Patient in shock.
resistance probably.
Hello?
Yes, sir. Probably a ceftriaxone, vancomycin, or linezolid.
No, just not probably. Just you tell what antibiotics you are in the duty, what antibiotics you will. Same case scenario. What antibiotics you will put?
Ceftriaxone plus vancomycin, linezolid, sir.
No, once you start vancomycin, you should not start linezolid. Patient in shock. Yeah. So why you will start vancomycin?
David, 1 minute. You want to
Sir.
give all 3 antibiotics, Tripti?
Sir?
Want to give all 3 antibiotics?
Pardon, sir?
You want to give all 3 antibiotics, sir.
No, sir. No, sir. No, sir. Not 3. Or because probably.
What are you going to give and why?
Sir? Hello?
Tripti, Tripti, you said the case scenario, patient in septic shock, you know, it's severe CAP, and probably this patient you would get to ICU. What antibiotic you want to start? You want to start 1, 2, or 3? How many antibiotics and which one would you prefer empirically?
Yes.
That's what Mohan sir is asking.
So, we have to start multi-drug regimen, multiple antibiotics in this case, because the first thing is the patient is in severe sepsis, as evidenced by high heart rate, falling blood pressures, At the same time, the patient is also
Madam,
probably.
it's okay, but you just prescribe 1, 2, 3 antibiotics. Number 1, number 2, number 3. You tell the names and dose.
Tripti, you can go back to your protocol, that table. And
And justify your antibiotics. Why you have started that? Depends on the clinical picture of the patient also.
Yes, sir. So the patient here is most commonly Streptococcus pneumoniae and Haemophilus influenzae. So I'm not very sure. Probably in this patient we have to start with ceftriaxone and also with MRSA resistant Staph aureus. Probably
No.
will.
Okay, madam. Anybody, any students, any IDCCM students? Hello?
Sir, good morning, sir.
Yeah.
Sir, respiratory fluoroquinolones, sir. Beta-lactam and respiratory fluoroquinolone.
No, you tell the
Like
antibiotic name. You tell 1, 2, 3.
Levofloxacin, ciprofloxacin.
Okay, levofloxacin. No, you tell one name. You will write levofloxacin or moxifloxacin or clindamycin or in the case sheet. You will write prescription.
Ceftriaxone.
Ceftriaxone.
Sir.
Yes. How much?
1 gram BD, sir.
1
2
gram
gram
BD.
stat,
Next.
sir, 1 gram.
Okay.
Levofloxacin,
Next.
750 mg.
Levofloxacin, 750 mg IV body. Next.
Yes, sir.
That's all.
Yes, sir.
Okay.
Azithromycin.
Again, azithromycin also or azithromycin.
Or azithromycin, sir. Respiratory fluoroquinolones like levofloxacin, sir. Injection levofloxacin. Or injection ceftriaxone plus injection in tablet azithromycin, sir.
Patient in shock, you will put tablet. Any? Okay. Any question? Any suggestions from the seniors? Tripti, how will you manage this patient first? Patient in shock.
Sir, David.
Anna.
So you want to ask her questions, huh? You please carry on.
Just I want to ask her, how will you manage this patient? Leave it about the antibiotics. So how do you manage this patient? Tripti?
Yes, sir. Since the patient has come with probably septic shock, immediately we have to secure IV cannulation and start the patient on we have to assess the volume status of the patient, start the patient on fluids and probably vasopressor also, noradrenaline. Along with that, immediately we have to start antibiotics also within the first
how much fluid you will give?
Sir, because the patient is in septic shock, 20 to 30 ml per kg we have to start the patient on, probably 1 liter or more, because the patient is in sepsis. Along with that, we have to give supportive measures like treatment for fever and antacid medication. Definitely in this patient, we have to start 2 plus antibiotic treatment. Patient has to can also be taken for investigations like chest, CT scan, to see the if there is any the spread, the actual spread of the pneumonia. Since RFT and LFT are within normal limits, I think fluid given liberally in this patient. Oxygen therapy should be started because around 86%. And then again reassess the patient time and again for any decrease in the symptoms or normal or improvement in the general condition, improvement of the vitals, coming back to normal, reduction of
Will you
noradrenaline
intubate this patient or will
required.
you put him on oxygen mask or will you put him on
We
NIV?
have to wait. We have to assess the patient. First, we have to assess volume resuscitation, start on NORAD, and then start in the meanwhile antibiotics and all, and we have to continuously reassess the patient. If the patient is deteriorating or if the patient the NORAD requirements are becoming more
Tripti, David sir is asking, his oxygen levels and other things. Would you intubate or what would you do about his
I would not
lungs?
right away intubate this patient, ma'am. I would wait for supportive therapy to be started and
Dr.
take a
Tripti,
baseline ABG.
what is her respiratory rate?
Respiratory rate is very high, sir, 40 per minute.
Huh?
Respiratory rate 40 per
40.
minute.
40 is nice.
Yes, it's very high, sir.
Then what will you do?
Yes, sir. Give fluid, assess the flow volume.
Tripti, regarding lungs, regarding oxygenation, they're all asking. You finished fluid resuscitation, vasopressors. About breathing, about oxygenation, you tell now.
So if the oxygenation is still not improving, then definitely intubation should be sustained.
Yeah, Dr. Tripti. Oxygen, a patient with a respiratory rate of 40. With a SP on nasal bronchs of 4 liters, SpO2 is 95. What will you do now?
Respiratory rate is high, so we have to go for intubation, sir.
Okay, will you try some other things?
Yes, sir. We try HFNO for some time, but probably
oxygen on 4 liters of oxygen, SpO2 is 95. You want to start on HFNO?
No, sir. But if the respiratory is high and the ABG is showing acidosis, then probably we have to think we have to go for intubation.
Is there anything before you can try before you go for intubation?
But NIV should be used with caution. Patient should be alert. So should meet the
patient is unconscious?
And the patient is not unconscious, sir. Patient is conscious.
Can try, no, NIV?
So we can try.
Abdominal surgeries, can we try NIV?
Abdominal surgery is done long back, no? What is the contraindication?
Yes, sir.
There was only scar, but there was no surgery recently done. And anyway, it was splenectomy, not on GI, not upper GI. And patient is conscious.
Yes, NIV can be.
Other students can also answer. Sinju, Mahesh, Shankar.
I think based upon the response of the patient to oxygenation, if we'll start with basic first, we'll start with an RBM, and then if the patient is not responding to an RBM, the respiratory rate is still high, then electively we can upgrade it to HFNO under caution, and then if still not sustainable on HFNO, then maybe upgrade it to NIV, and then after taking an ABG, if the response is not that great, then it
But this patient actually his respiratory rate is high. Just don't put this patient on because oxygenation is okay. You need the respiratory support. So directly you start this patient on NIV than HFNO and also non-rebreathing mask. Okay?
Okay, sir. Agreed, sir.
So you should cautiously observe. You should resuscitate with the fluid, give appropriate antibiotic, and then you maintain this patient on NIV. And the antibiotic basically the streptococcus and the staph, they doesn't need vancomycin or linezolid. And this patient came from the community. MRIs is very, very rarest thing. Means we have seen approximately around of streptococcus, of staph, aureus MRSA is approximately now 50%. We calculate both from the OPD and IPD. And but staph aureus rate itself is hardly around 10%. What we see, we discuss in the textbooks, is when compared with that, it is less. But here, you can start on a beta-lactam plus beta-lactamase inhibitors. Okay, you can start on ceftazidime, sulbactam, or tazobactam, as the patient is very sick, is in the shock. So, and depending on your antibiogram, you can start on either a vancomycin or a linezolid or a teicoplanin, depending on your antibiogram, as patient is very sick in shock and on respiratory failure. Otherwise, beta-lactamase inhibitors should suffice. Okay.
So the ideal choice of antibiotics you are saying is either an anti-pseudomonal beta-lactam, that is either piptaz, or along with an MRSA coverage like vancomycin.
No, see, what you need to do is, I would not put on vancomycin or anything. I would put this patient on a ceftazidime, sulbactam, or a piperacillin tazobactam.
So
what is
one.
the question?
Okay, sir.
What is anti-pseudomonal beta-lactam, Sinju?
So piperacillin, tazobactam, ceftazidime.
No, tell one name. What is the anti-pseudomonal beta-lactam?
The names, no, sir.
Name one name.
Meropenem, piperacillin, tazobactam, ceftazidime. Ceftazidime, yes, sir. All are anti-pseudomonal.
All are anti-pseudomonal, but if you ask the anti-pseudomonal beta-lactam, it is ceftazidime. You have to tell.
Okay, sir.
All are anti-pseudomonal.
Yes.
Even ceftazidime, sulbactam also is
anti-pseudomonal only.
Piperacillin, all.
Yes, sir.
So when you will start anti-pseudomonal drugs? Which patients you will put anti-pseudomonal?
When there is a high risk of MRSA, high risk of pseudomonal infection, which is suspected, like recent history of hospitalization, exposure to IV antibiotics, prior isolation of MRSA or pseudomonas in the patient.
The patient come with cystic fibrosis, known case of cystic fibrosis, admitted with severe community acquired pneumonia. What antibiotic you will advise?
Cystic fibrosis, I'm not sure, sir.
Anybody?
Patient with structural lung lesion.
Yeah. See that cystic fibrosis, anti-pseudomonal, all other thing, MRSA, and even Burkholderia. Burkholderia is one of the But we have to cover in cystic fibrosis. So to cover Burkholderia, what antibiotics you will start? Hello? Anna?
No idea, sir.
Okay. Anna?
Trimethoprim.
Yeah, trimethoprim will cover.
Trimethoprim.
She's bacteria. She wants to
Bacteria.
bacteria.
Okay, when you will start MRSA coverage? Patient came in a septic shock. When you will start MRSA coverage? Vancomycin or teicoplanin? And what is the percentage of community MRSA? On what type of patients you will put him on MRSA coverage? Tripti?
Yes, sir. Patients who are at risk for MRSA.
The risk of MRSA, who are at that risk?
Yes, sir. Very commonly, patients who are immunocompromised, who are having acute or chronic comorbidities, renal chronic dialysis patients, COPD patients, diabetes,
Yes.
patients who are on immunosuppressive drugs or corticosteroids. All these patients are at risk of multi-drug resistant organisms, sir.
So they will put you in shock, you have to cover the MRSA also. So
Yes.
along with your anti-pseudomonal drug, you have to put him on MRSA like vancomycin or linezolid, or in patient in shock, we should not start linezolid. Why? We have to give only vancomycin or teicoplanin. What is the reason for that? Hello? Chinzu? Anybody can answer. Hello?
Hello, sir.
Cheppu.
In shock, the rate of absorption of the drug would vary if it is an oral drug. So we should give an IV antibiotic with a predictable pharmacokinetics.
Linezolid also IV antibiotic, no? Why you don't give in shock? Hello?
Lactic acidosis.
Anna, Cheppana.
Lactic acidosis. Lactic acidosis.
Lactic acidosis. Yeah. Along with that, it is a bacteriostatic drug. So usually bacteriostatic drugs cannot be prescribed in a patient with septic shock. So you have to give a gram-positive MRSA coverage other than linezolid and daptomycin. You should not give daptomycin. You have to give vancomycin or teicoplanin. Okay, Anna, any questions from your side? We'll close the session. Time is over. Shall we close? Hello, madam.
Yeah, David.
David.
Thank you, Tripti. Nice presentation, and thank you, David. Nice discussion.
Thank you, madam. Thank you, Tripti, for a nice presentation.
Thank you, Tripti. Nice presentation.
Thank you. Thank you,
Yeah.
sir. Thank you so much.
Tripti, you please put in the group that PPT.
Yes, sir. I will upload the PPT
Yes,
in the group, sir.
Thank you. Thank you very much for a good presentation. Thank you all for your active participation. Thank you.
Thank you.
Thank you, sir. Thank you.
Thank you, Trupti. Thank you to all.
Thank you.